Good morning, everyone. My name is Jeff Kanige. I'm the editor of NJBIZ. Welcome to our discussion on healthcare technology. I think everyone who goes for annual checkups knows that technology is ubiquitous in the practice of medicine. It's not just the amazing medical devices that we get hooked up to, but information technology has made a wealth of data and health records available at the click of a user interface. Is that a good thing? Well, the same holds true for financial data and credit card records, and nothing ever goes wrong with those. Now, as in other areas, technology has made healthcare more efficient, more widely available. There are caveats. Privacy has to be protected. Health records need to be secure. And patients still need human interaction with their healthcare providers. Today, we're going to talk about all the ramifications of this technological proliferation. And we're pleased that Dean Paranicas will be leading that conversation. Dean is the president and CEO of the Healthcare Institute of New Jersey, a post he's held since March 2011. He started his career as an attorney at McCarter & English before moving on to executive roles at BD. Just before joining Hinge, Mr. Paranicas served as vice president for public policy at the company, which was formerly known as Becton Dickinson. He's also the co-chair of We Work for Health New Jersey and is on the board of the New Jersey Innovation Institute. Please welcome Dean Paranicas.
Jeff, thank you for that warm welcome, and good morning, everyone. It's really a pleasure to be here this morning. And you know, I'm impressed with the description Jeff described of what we're going to cover this morning, but I understood this was only like an hour and a half, not all day, because there's just so much we could talk about in the area. It's so robust and so comprehensive and so pervasive in terms of the areas that it's covering. And as Jeff mentioned, it's fascinating, particularly for me, having had the privilege of working for a large global medical technology company for most of my career with BD. So I have a keen interest in this area, and particularly having had exposure to it. And I'm particularly pleased to be moderating today because of the distinguished panel of experts who you'll be hearing from, Emma Yamada, Carl Scalzo, and Van Lee, who are engaged in hands-on development and leveraging of healthcare technology in their daily lives. And we appreciate that they've taken the time to join us today and share with us what they're doing. But before we kick off the panel, allow me to briefly tell you a bit about the Healthcare Institute of New Jersey, or Hinge as we are affectionately known, and about New Jersey's life sciences community. Hinge serves as the voice for the research-based biopharmaceutical and medical technology industry in New Jersey. Our mission is to expand patient access to the most innovative biopharmaceuticals and medical technologies and promote awareness of the industry's impact on New Jersey's quality of life and economic well-being. Now, as we all know, New Jersey has long been called the medicine chest of the world, and that's for good reason, and certainly our goal is to keep it that way. For example, 12 of the world's top 20 research-based biopharmaceutical companies and 12 of the world's leading medical device companies are headquartered in New Jersey and maintain a significant presence here. Now, as you know from my background, I'm an attorney, and I went to law school because they said there'd be no math. And the one thing I understand is if we've got 12 of 20, nobody else has as many as we do. And we represent 25 of those companies from both sectors, of which there are many across the state. Our member companies serve patients and providers worldwide and are a large part of an industry that contributes almost $105 billion annually to the economy of the state, or 18% of the state's GDP. And is responsible for about 10% in total of the state's workforce. Now, if you'd like additional information about Hinge and about our industry, I would commend you to our very robust website, www.hinge.org. Now, as we move to our panel, it's always very helpful to get a sense of the audience in terms of what your backgrounds are. So by a show of hands, how many of you are involved in some way or another in the healthcare industry of whatever stripe? Oh, that's great. Terrific. So we have an informed audience. So our panel is going to be prepared for some very incisive questions from you. But before we begin our discussion, which will be followed by a Q&A session where all of you will be able to pose questions to our panelists, I'm going to ask each of them to take a minute or two to introduce themselves and their work, and starting in alphabetical order with Van Lee. Van?
Thank you. Good morning, everyone. Can everyone hear me? Yes. Hi. My name is Van Lee, and I'm proud to represent the New Jersey Innovation Institute. I'm the senior director there of business development and programs. NJII in short whose parent company is NJIT, New Jersey Institute of Technology, takes on various projects, mostly when it comes to healthcare on the federal and the state side. So we're predominantly funded in those areas, and I'm going to be speaking more today about one of our largest state projects that the Department of Health has endeavored to take on, which is the New Jersey Health Information Network. And as it's described, it is the network of networks, and its purpose is really to create data sharing networks and safe sharing of data so that patients themselves can feel safe when they get care in New Jersey, especially when it comes to quality and, of course, connecting their continuity of care documents. So,
Van, thank you. Carl?
Carl Scalzo, Online Computers. My organization is responsible for helping to maintain, manage, and protect healthcare systems, their clients, the doctors, the information. We have a long history working in the community and a good base in New Jersey. Currently working with about 75 different organizations.
Thank you, Carl. Emma?
Good morning. My name is Emma Yamada. I'm the Director of Data Science at Holy Name Medical Center in Teaneck, New Jersey. My group is responsible for building machine learning and deep learning algorithms that are used to predict patient outcomes and improve the quality of care across our enterprise.
Great. Okay, so why don't we turn to our program? As I said, this is going to be a panel discussion, and we like to call it a conversation. So what I'll be doing is introducing the question to one of our panelists and inviting the other panelists to participate in the discussion of it. So we prepared questions covering a number of broad themes, which will be followed by concluding thoughts from our panelists, and then we'll take your questions from the floor. So the first category we'd like to talk about is privacy, data security, and data quality. So Van, when creating networks to share electronic medical records, what are the challenges involved with EMR?
Well, I'd like to start with in my everyday life, I certainly work with the provider practices themselves. And so my response is going to be from their experiences. And I'd say security, certainly privacy and security are very important when it comes to data sharing across networks. I think when it comes to what the individual practices deal with on a day-to-day basis, besides clinical care, is also the business side. In New Jersey, we represent small businesses in these provider offices. And so when you look at what the payer community, the insurance companies are looking for, which is, I think we're all on the same page about providing quality of care, they benefit from that, right? Their patients are receiving this high quality care. The providers themselves are really, I would say, motivated to share information across their practices because patients themselves go across different practices. But at the same time, they have to keep this information secure. I think we're all in the age of news, and so we see HIPAA breaches and in the news. And so you have one side saying, keep it secure, lock down. On the other side, which is, I think, where I really am pushing towards because I'm a patient myself, is that I want this information in my hands. I want to be able to see transparently where these clinicians rank when it comes to quality, because I can do that with everything else. I can go on Amazon and buy purchase items and look at their reviews and look at other customer reviews. We're not there yet in healthcare, but I think that that's where we'll be going towards. So I'd certainly say security and privacy are big concerns.
Carl, from your perspective?
Yeah, security and privacy is definitely a big concern. We've moved to this sort of open and transparent environment of sharing everything and wanting everything, right? Everybody wants everything on their smartphone, right?
Yes.
They want to know their blood work. The moment the results are in, they want to instantly see it. They want to use that new doctor that we've all been using for the past 10 years, which everybody hates, Google, right? And they want to know, okay, how could I upload those results and get another opinion? So it becomes this big, scary thing because this information that we're trying so hard to protect, we now have our consumers of the information are willing to share it at will. And how do we protect that information, right? And then how do we share it with our doctors, right? What do we do to protect that information? We struggle with it, right? And it's a balance. I think there's sort of a demographic of people that genuinely don't care if some of their information is out there and shared.
That's true.
Right? And then there's another demographic of people, consumers of this information, that don't want anybody to know anything. And they even want to limit the stuff that sometimes their doctors see, right? They want to be in control of the information. And I think these are all things that'll play out over the next few years. And I don't know if we can really talk to where it'll end up, but it's definitely a big topic.
Emma, from the institutional perspective, what are you seeing?
Sure. I think as an industry in healthcare, we have to learn from the mistakes of other industries in the past, right? So if our business is bringing all of this data together, housing it as a hospital system that's doing work on big data, so we're aggregating data beyond our individual health system and our individual providers. If big data is your business, then it's your responsibility to secure it, right? It's also your responsibility to make sure people understand how you're using it, right? So it can be challenging from a healthcare perspective when you're explaining how AI, how machine learning, how deep learning works to John Q. Public in the context of then healthcare, right? It's already complicated to explain when you're talking about retailers suggesting what you might buy in association with another purchase. Now we add in the complexity of diagnostics and pharmaceuticals and those types of things. So I think it's challenging, but it doesn't mean we shouldn't do it. I also think that it's a responsibility that we have to accept when you start working with this type of data.
And I
Go ahead.
put the 2 points together, if I
Sure,
may.
no, please.
I think that it's doable. I mean, I mentioned that it's a concern in terms of sharing data, but it is doable. I think certainly the headline that I mentioned, which is HIPAA breach occurs here and incidents here. If you read into the articles and read into what the incidents were, it was a laptop left in the car, or it wasn't a secure device. These are all steps that organization took, remediation steps to fix it, and they're all doable. So yes, the headline reads that it's scary and here's the hundreds and thousands of dollars out there, but when you really look into it, I think education is huge. Emma mentioned understanding of this, and we're working in a space where traditionally it was a paper record, stayed in the office, and when you handed that record to the patient, it's their responsibility. They lose it, it's their record. Now we're in a space where you have to share that because the consumer themselves, to Carl's point, wants that on a device. I do want to shop around. I do want to participate in a mobile application that'll help me with my nutrition regimen or other aspects of it. So I think understanding is certainly an area that we focus in on because it's not just doing the work, it's we're all on the same page and we're all working towards the same really goal. So.
Carl, I was struck by something you just said when you talked about this extreme between people who don't care if their data is out there and people who don't want their data out there in any shape, manner, or form. If I put a question to all of you, how much skepticism do you think there's out there among those who are sensitive about their data that their data is secure? I mean, it's a qualitative question, but people sometimes may be reticent to provide the data, not because they don't want to provide it, but because they're not confident that it's going to be maintained in privacy. So how would you respond to that kind of a perception? Or what are you seeing in terms of the populations you serve?
So, again, I think it boils down to sort of an age demographic. There's this younger generation that has an I don't care attitude, right? I want to learn as much as I can from my information, and who cares if it's public, right? I received a new bed yesterday, and it tracked my sleeping last night. So I slept for 5 hours. I got up twice for 42 minutes, right? And it knew everything about me, right? And is that healthcare? But to the point of, does it stop with the bed, right? I have a watch I don't have on today, but it's tracking my heart rate on a regular basis. It's transmitting that information back. Do I care, right? Whereas generationally, I talk to, say, my mother-in-law, who's like, why would you want anybody to know that? You have to keep that safe. Only your doctor should know. So I think, for my mother-in-law, she's genuinely worried who knows her info, right? For me, I'm like, who cares? And then I look at it from a business sense, right? I went for an insurance policy, and now I'm like, well, maybe I don't want so many people to know my information because now it decides my rates. So I think it's a time thing. I think we have to see how some of it plays out. And I think we're going to make a lot of mistakes along the way. I don't think anybody would disagree with that. It's a tough one.
Emma?
Yeah, I think some of the distinctions have to be made as well about whether the information that's being collected is tied to an individual or is tied to your general demographics, right? So, you don't want anybody who's going to insure you to know your specific sleep patterns to you, but is there value and can we create a distinction between collecting data somewhat anonymously? So if I know your age, if I know your race, if I know your zip code, and I know your sleep patterns, is that enough for me to do something without compromising your privacy, right? And so I think, in the past, there weren't very good rules in other industries, so everybody collected everything and used it any which way they liked. I think as, some of those things are changing, new regulations are coming down the pike across industries, new regulations are going to put in place what HIPAA has put in place for a long time. So people are going to learn to do more with less. And in the benefit of and in the value of privacy.
Van, anything you want to add to that?
I'd definitely say I'm probably one of those individuals that you've all heard of end user license agreements. When you scroll down really quickly just to hit accept, you never read any of that.
Well, you can't. If you don't hit accept, you can't get in.
Can't get in. You can't get in if you don't accept. So
The lawyers are clever that way.
They're clever, but again, it's literally all written down what they're going to do with your data and them sharing with third parties and making money out of those aspects. So, but you said it correct, Dean. I mean, I don't get in unless I do that. So I think what I would like to say is from a patient perspective, it's what are we getting into?
Yeah.
I think there's a lot of mobile applications, especially when it comes to health in this generation, where you can get insights on what's best for the community. I'm a type 1 diabetic, so what are other type 1 diabetics of my age range? How are they living their lives? And that's not something readily available, at least today, in a physician office, right? Because they didn't see those particular patients. So I think as individuals like myself, what am I getting into is a big question. But I think that once we all get together and talk about topics like that we can arrive at, I think, some common portals in place.
Now, an essential part of this also is the quality of the data, the old garbage in, garbage out. And I know that perhaps some of the skepticism undoubtedly is people who would be concerned as to whether the information is going to be distorted or inaccurate that ends up in their sort of a permanent record of their lives. What are you finding? What tools and screens and devices are used in protections to verify the quality of the data going in? Anyone you want to start with that?
Sure. So, on the AI machine learning side, we spend about 80% of our time doing what's called data cleaning, right? So you're just sorting through data and figuring out what's usable, what isn't. If something's such an outlier because they're truly an outlier and this really happened, or there was some kind of error, right? So there's a lot of time spent into doing that. There are whole business lines of AI dedicated to just cleaning data. One of the advances that you hope for is that as EMRs evolve, they move away from being billing systems and they move to being actual clinical documentation systems, right? So a lot of EMRs were designed to make it easier to keep a chart electronically and bill it accurately. Billing accurately is not always going to be reflective of a full clinical picture of a patient. So as those evolutions happen, you hope to see the data quality improve. But you have to acknowledge that even with the best system, you still have a human operating that, and there's still a chance that they input the wrong value into the wrong field. So you're always going to have an element of data cleaning that's just it's a reality of the business.
Carl?
I'm going to pass on this one.
Okay. Yeah.
Wow. I would certainly say, and Emma mentioned the 80% of cleanup. Globally, I've worked with organizations and healthcare organizations that have data. It's 80% of cleanup is really pretty much a standard. There's a lot of data cleanup that occurs, especially when you're talking about interchanging different languages of information. How do you articulate this provider's notes with this provider's notes, the patient's information as well. I think what has certainly advanced and helped is standard languages in sharing clinical documentation, medications, SNOMED, HL7. These are all technical languages that basically help make sense of this information and reduce some of that cleansing. But you're always going to be doing data cleansing, honestly. I think when it comes to the data that we deal with on a daily basis, it's important to keep it secure. So I think we're always going to really support models and have operations where you're looking at the data, testing it, to make sure it's safe and secure.
Great. So why don't we migrate now over to talking about the efficiency, cost reduction, and investments. It's a sort of a systemic conversation. And the first question I want to talk about is time wasting versus time saving systems, or as I like to call it, the heat versus light quotient. How much heat are you generating versus how much light? How much progress in your collective and respective views is being made in reducing the time required from users, especially physicians? And before you answer, by the way, there was an article that just came out yesterday that physicians were polled. This is an article from a New Jersey periodical that said that 2/3 of physicians polled feel that they're burned out. And of that 2/3, 37% said it's because of the amount of time they're spending on paperwork and compliance with government and hospital systems, provider systems. So with that as the backdrop, in terms of taking this data and converting it and integrating into a record, where do you see, where's that balance? How do we strike the balance in the right direction toward time saving and efficient systems that are adding value rather than being perceived or actually being counterproductive?
Sure. So I think, that burnout and that wasted time are the reason that teams like mine exist, right? So our whole goal is to figure out that problem and say, how do we automate as much as we can automate, right? So how much do we lift off of a provider? You look at EMRs, how many times does a provider move through a single visit and enter the same information 2 and 3 times, in various places in the software, right? So it's about taking technology that we now have that may not have existed when these EMRs were first created and evolving them, enhancing them to take advantage of some automation, right? I think there's a flip side to that, right, where people are somewhat afraid of automation, but not jumping ahead to that problem and just kind of focusing on, how does AI solve some of that burnout, some of that redundancy, right? And making sure that when you're capturing data, you're using it to not just impact outcomes, but also help your providers get through their day.
Mm-hmm. I think to Emma's earlier point, today these are billing systems, right? So efficiency is really not there because the concern is about proper billing. I don't want to say something too far out, but it's sort of contradictory to the healthcare practice. Everyone touching the computer is worried about what the bill is going to be and how, if it's properly coded and things like that. Mm-hmm. The focus isn't on the healthcare portion, which is a little bit on the scary side. So I think we're in this evolution, right? Life and technology goes through these evolutions. So how many people in the audience have an iPhone? Everyone. How many people have been to the Apple store? Painful, right? Super painful, right? But this is towards this evolution. So the other day I bought a new iPhone, and as I walked into the mall, it knew I was near the Apple store, and it said, "Would you like us to have your iPhone ready when you walk in?" I said, "Yes." It said, "Meet us at the iPad table." Great. Give us a brief description of yourself so we know what to look for. I said, flat top haircut, blue shirt, and eyeglasses. When I walked to the iPad table, there was a young lady bringing a bag, and she had my iPhone. She said, "Could I see your receipt?" I held up my iPhone. She scanned it. She said, "Do you need any help?" I said, "No," and I left, right? So how do we apply this in sort of the medical industry? I'm showing up at the hospital, and my vitals are being collected via wearables. My information as I walk in and I'm in the ER or wherever is now in the computer, right? That's where the change will happen in the industry when we move from the focus of collecting information from billing to pushing information to the provider to make it a more efficient experience, right?
Yeah. No, I wonder where that workflow is. Yeah, according to your point, to hospitals pre-authorization, you have to deal with all of those papers. Even when you go from department to department, you have to register
start over
sometimes again. So
rescan your wristband, right?
Yeah. So I think automation and processes is really an important point. At the New Jersey Innovation Institute, we work with 70 or so practices, over 300 clinicians in submitting their immunization records to the Department of Health immunizations. They built a fantastic system which allows their systems to actually just consume the dosage and delivery information for those patients. So that saved time for the office where they would used to manually have to transcribe and write down the notes and enter that into that system. So the amount of time saved for that clerk or that person at the office versus now the doctor can order, prescribe, and then that system just automatically gets populated. I think it's quicker for insights, but that's part of what we focus in on is where can automation really support manual processes that really are simplistic and tedious. So,
Are legacy systems still a problem in institutions? I mean, where you have like subsets that have difficulty talking with each other, or are we kind of past that point at this point largely?
I don't think we're past it at all. I think everybody is still living on their own islands. Our island at Holy Name Medical Center is a little bit different because we build our own software. So we have our own proprietary EMR. So it makes us a little bit more flexible than sometimes others. And others have islands with walls built up around them because that's the way the software was designed, because it's a business proposition to make it difficult to get in and make it difficult to exchange data, right? Because you can charge higher fees to build the connections. So I think it's absolutely still a problem. I think people are becoming more informed about how valuable data is. So as patients and as consumers of the healthcare system, I think patients will be the driver to people becoming more interoperable. And I think as, advances in automation and AI kind of prove themselves out, people will understand to do those things effectively, you need more data, which means we're all going to have to cooperate and share data more.
Would you gentlemen agree with that?
Yeah, I would definitely think so. Like I'd mentioned earlier, when it comes to better outcomes and when you focus on better patient care, it is about interoperability and connecting those systems. I'd like to really mention one point, which is these EHR systems that we talk about. They have to be there is a certifying body that watches them, and their current certification is called the 2015 certification. We're in 2019, so that in itself.
What's 4 years a month, right?
Well, I mean, we know how fast information is moving, use cases are being developed, incidents are happening, security. So we have a lot of catching up to do, and I think that when it comes to connecting, that legacy systems certainly still exist.
So we talk about these systems and we're talking about outcomes, and that's obviously critical. But from a financial or investment perspective, in terms of the ROI that's involved with this, are we talking about systems that are merely paying for themselves, or is the goal obviously to reduce costs? I think that's something that I know that I'm sure that our audience would be interested in wondering about. In other words, outcomes are obviously up here, but at the same time, though, what does it cost to get there? Mm-hmm. Anyone?
Yeah, I'd like to go. So from my experience, again, working with, I think, these small practice providers who have invested money into purchasing an electronic health record system, they all started in 2011, 2012, when the federal government released this law and this rule called meaningful use, and an incentive tied to meaningful use. So at that point, it was monies to purchase electronic health record and implement these automatic modules. So from the private practice perspective, the cost that I've seen was not just purchasing the system, but also adjusting their office staff to the changes in workflow. It's no longer pulling down a chart physically. It is around, do you know how to navigate through these specific screens and pull down this information? You just got a PDF document sent to you via secure email from a specialist for your patient. How do you now upload that and add that to the chart for the physician? Oh, and in the meantime, let's have that generate a report that needs to go to the insurance companies for billing purposes as well. And let's make sure the data is clean because it goes into a portal application that the patients are going to have to reinterpret, right? So this is what, when I talk about cost and the impact of it, that is a big change for offices.
I think creating efficiency is happening, right? So we don't have big rooms with medical records anymore. So yeah, there's efficiencies, right? We're not buying as much real estate. We're not printing as much paper. We're more consciously using technology and leveraging technology. But again, I think we're in this sort of infancy. We're still struggling, right? We're struggling with, again, what Emma said, sort of these islands of information. And all we've done is really added more islands, right? So I think we're heading in the right direction. It's a matter of time to get there, right? How do you get information from your old school doctor who needs to transmit this information but still has an AOL account and the reality?
Dial-up?
Yeah. You'd be surprised how many people still have an AOL account. And they still have those.
That's scary.
Yeah. And they still have those CDs that came in the mail too.
Are they good anymore?
Showing age, right? No, but I think we're heading there, and I think with AI, this will accelerate the process. But I think if you step back, right, what happened in 8 years ago with the sort of strong arming, which I think was a requirement really to be in the EMR, business, right? Do we need another kickstart again today? Do we need something else to move us along, or will it happen without us doing anything? Mm-hmm. Is that mindset already there, right? You're developing your own EMR system, right? So it's initiative. You're using this as, I would say, a competitive advantage against your peers to make it a more efficient process. But are you the exception, or are you now becoming the rule in the industry of, will we have more people doing this? And again, should we have another kickstart? Should government be involved, right? I know that's a scary topic for most, but I think if the government didn't step in 8 years ago, we wouldn't even be having the conversation today.
Well, it's funny you mention that, because about 15 years ago, I was in a major conference in Washington at the infancy of all of this. And we were all shying away from the dreaded M word for mandate. And everybody was worried that the government was going to come in and mandate a standard for EMR. And but that was back in the prehistoric era compared to what's happening. Emma, what are you seeing from your perspective?
So I think that it depends upon what you define as a return, whether you're seeing a return on the investment of purchasing an EHR today, right? So if avoiding penalties from some of these mandated regulations and reporting systems like meaningful use and things like that, if you constitute not having that fine imposed against you as a return, then your EMR is probably giving you exactly what you wanted it to. I think Holy Name will remain the exception in the sense that we develop our own software, right? It's its own challenge. It's its own business line, right? So as a healthcare system to take that on, yes, we believe it provides us a competitive advantage, but we don't know that we see other people in the space kind of jumping onto that idea wholeheartedly or getting into it knowing everything that comes with it. Mm-hmm. But what I hope isn't the exception is the initiative, right? So if you're not a system or a provider who develops their own software, but you've purchased a system, and it's time that we start going to those systems and those vendors and saying, we need more from this technology, right? Mm-hmm. So we should see customers of EHRs demanding more from those systems because the technology exists. So it's now about delivering that technology in a way that works.
Okay, well, why don't we pivot over and look at things from the patient's perspective, since we're all patients as well as we know. We talked about, you've mentioned there are implantables. We talked about wearables. We've talked about mobile apps and all of these amazing tools that are available. So from a patient's perspective, how are all these technologies helping to improve the quality of their care relative to what's been happening with the advancements? Van? Sure. Just kick that off.
I'm going to start with the patient having information in their hands. I think starts with quality. I mean, when you talk about quality, you're talking about specific outcomes, results that are driven now, I think, since we have data based on social factors. If I'm a diabetic and at my age and I'm not eating correct and I'm not watching what I work out, my workout schedule, my sleep schedule based on my wearables, most likely I'm going to have an event at an earlier age than if I had taken care of myself. So I think when it comes to quality and technology, it really does start with awareness, self-awareness of where you are and also where your community is. And I think resources when it comes to improving quality really don't just reside at the provider office. I really think it's around meeting other patients very similar to yourself. I also think with technology, it allows me to support personally my family members, my aging parents, my grandmother, who, yes, have been provisioned a patient portal, my 97-year-old grandmother, provision a patient portal, which she has to log in via email, reset her password, log in, add a security question. That's not happening. But what we can do is allow me access so that I can see what prescriptions have been prescribed to her, and wearables that help me understand if she had a fall event, et cetera. So I think connecting the community and really now getting into the community, I think there's an opportunity for that because, like Carl mentioned earlier, we are used to using our phones, and that's all driven by data. So where do we bring that all together is where NJII in particular is really focused in on.
Carl?
I would say that it's the balance of that data, right? Yeah. Sometimes having so much information at your fingertips is a little bit on the dangerous side, right? And I do a lot of analogies, and I'm sorry if it's too much. I had a friend who, again, collects all this information, an avid runner, way healthier than me, and each week his run is going down, right? And he's tracking all this information. Eventually he ends up in the doctor's office and says, I got cancer. I know it. I Googled. It's all the signs. Doctor, slow down. Relax. What makes you think this? Well, I was tracking this stuff with my iWatch and this. And let's run some tests. Within 7 days, by the way, he had a triple bypass, by the way, didn't have cancer. But again, it created this sort of too much info, self-diagnosis. It's a balance. And where are we on that road of we're empowering ourselves? It's great when we're buying a bed or some commodity item, but where does it fall in play with our health? Because it also causes sort of unnecessary, to a certain extent, communication with our doctor because we're second guessing the expert who 20 years ago, we never even knew any information until we talked to the doctor. So again, I think it's about finding that balance, right? And then, where does AI play into this moving forward when potentially if this technology is released on us, and now the technology is giving us advice, and potentially the doctor's out of the mix, will that happen? Right.
So I think keeping the doc in the mix is part of improving the quality and where this type of data and where AI has a lot of opportunity, right? So yes, having a lot of the information in the patient's hands can be helpful, it can be empowering, but I think where you're talking about improving quality, the quality of your care is not necessarily going to be improved by the number of times you nag your doctor to do something better, right? But what is going to be improved is when your doctor's seeing 50,000 patients a year and you walk into the office once a year, they will know more about you. They can personalize your care to you better because they have all that information in front of them, right? And they're not expected to remember your one annual visit through the 50,000 visits that they have in the year, right? I think that's where quality starts to be improved for each individual patient, not just across the system, but for each individual person.
And one aspect of this that comes to mind that we talk about often is medication adherence. And as we know, and we're all patients in this room, and I know every one of us takes the drugs exactly the way our doctor prescribes them for as long as the doctor prescribes them. Am I right? Of course, that's a truism. But the reality is that people don't do that. A lot of times the statistics are staggering about how often patients don't fulfill their prescriptions at all, or don't renew them, or don't take the drugs the way they're supposed to. And that costs our system an estimated $300 billion with a B dollars a year in terms of total costs and impact. So I would think, and I'm posing the question to all three of you, that a lot of these tools can be very helpful to help patients maintain the regimen they're supposed to make. And Van, I'm particularly thinking of you as a diabetic. Yeah. It's one of the areas where adherence is critical to your well-being. So can you just comment on that for a moment as well?
I think this is an avenue that hasn't yet been explored with wearables, right? Everybody, when they talk about wearables, is very focused on EKGs, right? Heart rates, number of steps, potentially adding blood pressure and temperature into the mix, right? But those are vital signs. Those are going to help us diagnose, unknown prolonged QT rhythms or things that are, very latent, but then can be very deadly, right? But those are really, the percentages of people that impacts are small, right? Wearables hasn't yet explored this concept of compliance, right? And being a reminder system or an alarm, right?
Or a zap.
Right. Yeah. I don't know if we'll go that far, but, how many people use their cell phones as their alarm clocks now, right? Because you don't even not sleep with your phone now. I mean, it's reached that point. So to use a wearable to say, not just monitor vital signs, but also then say, hey, it looks like you haven't taken your medication, or to use even the phone. We haven't really used that as an application. But I think it's one that's dying to be tried.
I love that idea, what Emma mentioned about, so for patients, I can speak to, and correction, I'm not a diabetic. My friend was, so my mistake. Sorry. My mistake if that was confusing. But I would say that I don't choose the medication, or I'm not adhering to the medication, probably based on how I feel that day. If I feel like I'm feeling better, why do I need to pop this medication?
Happens to be the case with antibiotics in particular.
Well, right, yeah. and
take
so
them for 10 days. But
if a wearable says, wait, you're spiking. Wait, your levels are going up and down. That's facts. That's really facts. And it's also telling you, right, okay, I'm going to take my medication because I can see feedback-wise. My phone is alerting me. And that will cause me to miss my day at work tomorrow or go to my friend's party, anything of those factors. So I think healthcare in general is moving into that space. Certainly from a patient perspective, that's where I'm coming from.
I think, one of the other things that's difficult about this problem is it requires some input from the patient or the person on the other end, right? So if it's not a medication that's going to directly affect your vital signs or something that we can measure in a real-time way, how are we going to know you didn't take your medication, right? So there are very expensive solutions to this that are literally different types of caps that you put on top of pill bottles that check how many times you open it. But now you're talking about collecting. That pill bottle has to be somewhere where there's a Wi-Fi signal so it can send that message out to me so I can know that you didn't take your med, and then I can remind you, right? There's a lot that has to come into play. And those caps are like $100 a piece, right? So someone's on 10 medications and you have 10,000 patients that have 10 medications. Yeah. That's cost prohibitive for any organization that's trying to push medication compliance, right? And medication adherence. So we have to use, or hopefully use, technology in a way that can bring that cost down, and also maybe remind patients to tell us whether they took their medications so we can remind them to take their medications, right? I mean, that's a challenge that we're in right now.
There you go.
And the pharmacy doesn't forget to tell us to take our medication, right? You need to pick up your prescription. It's time. And that also drives up costs also, because people that aren't using those prescriptions now are collecting the medication because the pharmacy is telling them to, right? So now they have 6 pill bottles in the cabinet that insurance paid for. The patient didn't consume and nobody got helped, and actually multiple people got hurt, right? You paid for it in your, healthcare bill, right? The client, the patient is paying for it in his health, right? And okay, the pharmacy made a little extra money. But those reminders, they're getting smarter. The pharmacies are pushing the information. I think it will get to the point where they remind us. If not, I'm sure somebody already has something that nudges you every so many minutes to take that morning pill, that afternoon pill.
So we're heading in that direction. So let's talk for a moment about a trend that's been happening, and it was actually a product of the enactment of the Affordable Care Act, and that's outcomes-based reimbursement versus fee-for-service. And certainly it's still developing and evolving, and we still have lots of fee-for-services out there. But when we look at the fee-for-value model, obviously this requires good data about outcomes. So how are these advances contributing to that in terms of how systems and institutions and providers and payers can measure whether or not the outcomes are improving relative to whatever the metrics would be that would justify payment? Van, you want to start with that?
Yeah, of course. And I didn't get a chance to read that article you mentioned about physician burden and office burden. I'd say majority, again, based on my experience with the practice, is of that burden is around quality reporting and justifying the reimbursements for an office, based on the hypertensive scores, for my particular patient. If you actually start looking into the individual quality measures, it's really tough for the office. We're talking about them getting reimbursed on a panel of diabetic patients and how many of them were in control based on the last visit you had with them. So that becomes a performance percentage that gets posted for physicians. Yet these patients go across the board. They might be spiking because of specific reasons, or they're in control, but they don't have that information and data. So they're stuck trying to gather all this information electronically and submit that for a particular payment. And again, we're talking about physicians who just in the past 10 years implemented an electronic health record and had staff that were focused on paper records and knew that workflow in and out. So NJI in particular really looks at supporting physicians around this space. And it is, I'd say, certainly what I've seen providers and practices that have been successful are those that do open their walls and kind of work with organizations like Carl and our organization, because then that gives them the awareness and education and also some of the tools that are out there, to support them in this change.
Well, Carl, you've been invoked. If you could offer your perspective on this.
I'm going to take a pass on this one at the moment, only because I have to just give it a little bit more thought.
Okay.
So
Emma?
I think value-based care is going to be the catalyst for providers working together as a care team across health systems, right? So embracing solutions like the HIN, right? Because today everybody's kind of used to living in their own island and operating in their own island, and I charge a fee for this service, and that's it. That's the beginning and end of it. But value-based care starts to push forward those concepts of outcomes and outcomes that lots of different providers at different points in the patient's care cycle can have an impact on. So are we stronger together on a value-based care model, or are we, am I going to try to be the only kind of lord over this patient's care, but take responsibility for every single one of those metrics, some of them being very difficult to measure? Or do I invoke the help of other providers around me? And to know who to ask for help or to know who to collaborate with, I need to be able to share that data. And I think that's where the HIN comes in. I think Van and I were talking about this before. Hopefully this is the same time next year we're talking to you about a very different AI solution about collaborating, sharing data. It's a year too early for us to be put on a panel together, but we hope maybe we come next year and we're talking about how AI with collaborative medicine, with shared information, can really transform how you deliver value-based care.
So we're already setting the program for next year, right?
Basically.
Carl.
So here's a question to both of you. Do you think it'll happen without a nudge from someone else, right? And then two scenarios that have come up. We use the government, and by no means my topics reflect political views, right? We had electronic medical records because of a nudge in government. We had quality of care because of a nudge in government. So will this next stage happen independent, or do we need another nudge, right?
I personally, I think value-based care and some of the incentives around value-based care are the nudge, right? And I think it's not going to be a nudge for, a Cleveland Clinic or a Mayo Clinic or Cedars-Sinai, right? These massive systems, right? It's a nudge for systems like Holy Name, other North Jersey independent hospitals, right, throughout New Jersey, where the potential incentives are large enough and attractive enough that it's worth kind of making the investment of making this change, right? And as those smaller systems become successful with these types of programs, capitated models on the commercial side, right, that's where other larger systems will hopefully take notice and say, oh, hey, wait, this is an opportunity, right? And then it's going to be tested out, right? KFC isn't launching their meatless chicken in 1,000 stores. They're putting it in one store across the entire country, right? You have to try some of these things out in smaller environments, really fire test it, and then bring it out, right? So I think if you use value-based care as that nudge, that can be the nudge, and then the catalyst is just, hey, it works, right? And then other people want to join in on that success.
I think that's a great point. I'd say, in my experience, certainly when it comes to legislation and the nudge from the federal government, I think they are also reacting to data and the fact that Americans are dying and we're in an opioid crisis today. And so they're in a position to create legislations and mandates to really support that. I think when you look at electronic health records and meaning of use, I remember being in school at that time, industrial engineer, not going into the healthcare field, and learning that one of the leading causes of death for Americans was adverse drug events. The fact that drug interactions weren't detected at the point of care because they're on paper records. So that was the impetus for a lot of putting electronics, using technology to correct these issues. It was, imagine being, that being your family member who was a victim of that. I mean, that's just a needless, senseless way, I think, to really go. And so, I think that at the same time that the federal government, I think, is nudging and the state themselves are nudging, I think it is based on what we as, I think, human beings really want to correct. And I think technology and healthcare can really be powerful in that space.
It seems to me when your biggest customers are CMS and state governments, that can be a nudge in and of itself.
Right.
Yes.
So Van, before we go on to, in the interest of time, because we're going to get to our questions, 30 seconds on the Health Information Network to elaborate a little bit more for the benefit of the audience.
Yeah, sure. And this will probably tie in well with what Emma was alluding to. So the Health Information Network at the state is owned by the Department of Health in New Jersey. And I think the most important concept of the Health Information Network, New Jersey, HIN, is that we've all agreed as a state to share information. The members of the NJ-HIN are in their regions, in their geographies. It's about hospitals, it's about community providers, it's about non-hospital facilities, rehab, surgical clinics. We all agreed and worked over 2 years to come up with a legal form of agreement to secure and make this health information for patients private, right? And to make sure that it's private and secure. So we are an organization of those that said we're going to share information for specific purposes. And one of the first purposes, and we're proud of this, is we are the first statewide ADT exchange. ADT stands for Admission, Discharge, and Transfer Notifications. So finally, community providers, accountable care organizations, clinically integrated networks can receive notifications for their patients when they do get admitted or discharged across any facility in the state of New Jersey. And why that makes sense is we have the Turnpike, we have the Parkway. If we get into an accident, we're going to go to the nearest emergency room. So at that emergency room, do they have the most recent information, your allergies, your medications, et cetera? So this group agreed to share information so that we can really focus on what really matters most to New Jersey. And it's run by the Department of Health, and NJBIZ happens to be its contractor to operate and manage it. So.
Thank you. Well, why don't we move to questions, and I'll ask to hold your concluding thoughts to the back end after the questions. So please raise your hand, and I'll try to recognize you. And then we have a microphone that's coming around the room, so when you're recognized, if you could just please wait for the microphone and identify yourself and your affiliation and to whom you're presenting the question. So let's get started. Who's going to kick this off? Okay.
My name is Jerry Gavin. I'm from a company called Connect America that does remote patient health monitoring. I had a comment and also a question. One was in terms of medication adherence. Our company, for example, has a medication management machine that can dose up to 4 medications a day for about $30 a month and does notify a call center, which will text you or email you or do any number of things. But my question was about the nudging, which I think is so interesting. The senior population is about to move within the next 5 years to almost 25% of the entire population. Do you see that in itself as becoming a major nudge, as this is a population that is perhaps maybe the major market in healthcare at this time, and will that in and of itself kind of move in that direction?
Who wants to kick that one off?
Sure. So I think, nudging anyone has value. I think, that the age group, there's a lot of talk about, do they use technology as much? Do our seniors today actually, everybody in this room has an iPhone, but do they have iPhones? We have to think beyond regular applications, right? So, okay, yes, everybody in this room has an iPhone. Maybe not every senior has an iPhone, but I bet you they have a TV. And we have smart TVs now. So nudges don't need to just be on single devices, right? We have to think about finding people where they are, getting that information to them where they're at, because that's where they're going to use it, right? And getting beyond the, I require some input from you to then send back to you some information, right? If we receive enough input from other people, so you receive enough input from maybe 20, 30% of those seniors, can you generate meaningful nudges for all 80 to 90, 100% of those seniors that maybe aren't using technology? Right. I think, that's where the applications need to grow, and we need to look at using other technologies to do that.
Right. And I'd say, especially when it comes to seniors and their interaction with technology itself, some seniors, like my grandmother, do have the benefit of individuals that care for their health, their family members, and they're open to accepting these notifications and this information and nudging the family themselves. And so this comes under a program called Person and Family Engagement, and this is a new program that's really going around when it comes to practices themselves. And it really is focused on getting practices to create patient advocacy groups, advisory groups. How do we deal with specific populations in a community area? Are there resources? Are there YMCAs in the area? We're in Newark, so we have a predominantly Medicaid population underserved. So what resources out there for those that have housing insecurities that result in them going to the emergency rooms versus dealing with their housing insecurities? So I think it's really around leveraging, again, technology, but focusing on those outcomes, because that's when you really get into the applicability of that technology and that tool.
And can we leverage community to help with this, right? So especially senior population, community is very strong, right? So maybe you don't have everybody that has access to technology or whatever, but through community groups or organizations, can collectively they get their needs served and leverage technology through the group, right, versus the individual.
Great. Okay, who's next? Let's go to this side of the room, that gentleman right there.
Hey, great panel. I'm Joe Carr from the New Jersey Hospital Association. I love a lot of thoughts you guys are sharing, but I want to get back to something you guys said earlier when we were talking about EHRs and when there was first funding for that and meaningful use requirements. There were, I think the first rule came out with 25% patient engagement in terms of logging actually into their EHR at least once. That failed miserably. And then CMS backed off on that and got it down to 10%. That failed miserably. Then you get back down to 5%, and that failed miserably. So I guess and I'm a technology person, and I don't want to log in and remember my security password and my right questions. It's just not going to happen. So lesson learned there, I think, is a couple of things. One, especially for healthy patients, they're not going to take that time to do that. But I do think that we're in a mobile world, as you guys pointed out, and or whether it's your TV or whether it's your desktop or your phone. CMS and the ONC, the Office of National Coordinator, just passed a proposed rule that is going to force EHR vendors to open up their portals to app vendors. So typical mobile app vendors or program vendors. Do you guys think that's going to have an impact on patients wanting to get engaged with their information on a more frequent basis? Or do you think this is just going to be another, just like with EHRs, just no one's going to do it?
Who wants to take that one on?
So I think it has the potential to grow into something that patients engage with. I think alone it can't be without other institutions like the New Jersey HIN, right? Because if every application has a different set of data on the same one patient, then the patient has to go to 10 different places to manage all of that information. And it's not the patient's responsibility to keep track of, oh, my provider over here uses Epic, and my provider over there uses ECW, and my provider over here uses Holy Name System, right? And all three of those have their own apps, right? I think part of what that CMS regulation was hoping towards is you're going to have technology companies create apps, and then it becomes one app for the patient. But the reality is every single one of the existing EMR vendors has its own app already, and now you're just adding more people into the mix. So potentially patients at the minimum are going to be looking at 1-2 applications. And to your point, they're not logging into the first one. They're definitely not logging into the second and the third and the fourth ones, right? Yeah. So the information being shared across means that all those applications basically get put on a level playing field in terms of the data. And then it really becomes about the app's functionality. So I choose a particular app because I like the way it looks, I like the way it works, but it doesn't matter where the data is. Once you reach that point, that's where people start engaging, because it's not a burden anymore. It's actually, like Van says and suggested, it's engaging, right? I can learn more about all of my health records collectively, and I can understand how this is impacting my health collectively. But if I have to go to 10 apps to do that and then create my own spreadsheet to organize all, it's not happening, right? So we are in the process of getting there, but without the information being shared, I don't think we can get there.
I think we just have, healthcare aside, I think there's just so many different systems, right? We struggle with things with logging into computers and systems and programs and apps today. So I think, is there sort of a holistic approach to me as a person? Instead of me having to authenticate to 19 different apps and one of them being my healthcare, is there a way to sort of have a dashboard, probably not the right word, but something that presents me as me, whether I'm making a purchase in a store or going to my healthcare provider, instead of it being 400 islands, I'm presented or sort of being looked at as an individual, right? So if I go to work, how I get on my network is the same as how I make my purchase at Starbucks, as the same as I get admitted to the hospital. Is that coming anytime soon? I don't believe so. I think there are lots of smart people thinking of ways to do that, but I think it will happen. I think it's just a matter of when.
Yeah. And I'd say I love the app community. I think the app community is fantastic because, and I've got to speak to them. Again, my organization, I'm business development, so I go to HIM sessions, national healthcare technology, and I love speaking to the app developers because while I think EMR vendors and even we're developing technologies to focus on the business experience for the providers, the app community focuses on, I think, the life experience, the engagement. These app developers are not focused on how do you report on this information and this quality. They're not. They're focused on let's make this a game. Let's earn points for engaging with this tool. You know what? How am I doing today? Let's read this advice. Let's read this book. Things that really engage people, right, into using devices. And I think that that's what I'm really excited about. And imagine now if they actually had the tools to engage you even further and improve your health tied to it, right? So now that game that you used to play, that you love to play, answer this particular question that relates to your health care, right? Is there a mammography center near you? Would you go there, right, to get your annual screening? Earn points doing that, right? And so that's something that's, I think, in the healthcare community we're not experienced in. And so bridging that together, I think, is where you really get the masses to really engage in their own healthcare. But also, from my perspective, I get to look at the data. I get to see these interactions back and forth and see what works and what doesn't work, and then bring that hopefully back to you all and share that information.
Thank you. Okay, next question. Let's see. We'll go right to this gentleman right here.
Thank you. And thanks for being here and answering some of these questions. I'm Kirk Bashford. I'm CEO of General Devices, or GD. So we're a med tech company, and we're in that app space, that software space. It used to be more of a device space, but we're into the software world like everybody else. One of the aspects that you didn't touch on, maybe we can get a couple quick comments on, is we talked a lot about the telehealth side of it, which I look at as more the information side, the data gathering side. Then there's the telemedicine side of it, which is more the active patient care aspect of telehealth and telemedicine. And we do it in an emergency setting, so from the back of an ambulance or in your home to a hospital. But you see it every day now, telemedicine, and being able to visit your doctor remotely and not have to make that journey to the hospital, and cutting down some of those barriers. So that's changing some of the paradigm. A couple quick comments is we talked about the incentives and the regulatory. So we look at it, there's a carrot or a stick. And a carrot can be, incentives in forms of money, and certainly, and stick more on the regulatory side. And things like penalties for readmissions to the hospital. Well, those are initiatives and pushes for looking at outcomes and managing those patients better so that they don't end up back in the hospital. And it all kind of comes full circle. And we all knew this growing up, right? An ounce of prevention's worth the pound of cure, and the dollars are there. But it's really the dollars and the regulation that kind of drive these things. Even though technology is great and can do all kinds of things, without the incentives and the drivers to use the technology, it just becomes cool technology.
Comments, reactions, impressions to that?
So I think that, for AI at least, and for ML to be meaningful, we need people to generate data, right? We need lots of data. Our team usually says we're very data greedy, data hungry, because we need lots of data points on lots of different people. At this point, we've learned to kind of build models without knowing a lot about the individual person in terms of like who they are. But so long as we have basic demographic information, we can work with that. And then we can turn that around and tie that to patient outcomes. But you're absolutely right. If people aren't interacting with the technology in a way that allows us to collect that information, then for us, we don't have anything to work with. And I think, incentives have to be there to help, organizations to push patients to use these devices, or for organizations to invest in things, devices that help with medication adherence. But I think it's the same as kind of, KFC putting their chicken in one store, right? You start small, you incentivize everybody, you get the buy-in, and then you scale it out. But without the buy-in, if it's a relatively new idea, sometimes it's difficult to get everybody on board and get everybody kickstarted.
Is there really fake chicken?
Yeah. That's a real thing.
There's fake meat, right? There's the Impossible Burger.
Yeah.
Oh no, the burger I heard of. I never heard of the chicken.
Yeah, it's made with peas.
All right, shut it down, Ron.
There you go.
I've derailed them. Sorry.
Okay. All right. Did you want to add anything to that?
Not more than I think Emma had covered.
But I think to your point, point is more it's about the nudge, which potentially helps, right? It's that carrot stick. Money ultimately drives the direction.
Right.
Is it taboo to say it's the money versus the quality of care.
But you know, the hundreds of millions of dollars that readmission had cost. I mean, if you look at the nudge and the programs that have been developed around it, readmissions had decreased, right? So I think that we're right-sizing the system itself. I think we're in that constant phase, which is why I love it. I'm in quality improvement. And so I think at the same time, this is why the app ideas come really into play, because we can't really make these decisions and insights without the analysis. And the analysis doesn't come without a lot of information. Yet, right, seniors are being pushed patient portal apps versus applications that they would actually use or their family would use. And so I think we're in that space now today. And like I said, I think within the next year, we should convene again and really see where these apps have come into play, because Joe had mentioned that proposed rule that opened up these systems. That's a proposed rule. It's public comments. You all can log in and actually comment yourselves and your ideas. It's our country. But based on where you go, you can see that these EMR systems are now asked to share information, hopefully in the hands of these app developers who can get us the data and help us right size, I think, this system.
Okay, next question. More questions. Judith.
Yes, hi. I'm Judith Schaff, also from the New Jersey Innovation Institute. I wanted to go back to the topic where you talked about the value of patients' data. I happen to sit on the university's IRB, so that when people are coming in to do various studies, we've got to get approval. Do you think that potentially as part of some of your systems, and really I'm thinking about some of the big data stuff, you'd like people when they in the beginning say, hey, you can have all of my data so that it can be anonymized and go into some of these algorithms and studies that you're doing sort of in advance. I'm saying, whatever, is in my record, I'm willing to make available, so that would really help with some of the big data and deep analysis, machine learning that you're trying to do to help drive better patient outcomes.
Absolutely. I mean, in our world, the more data, the better. And we, in light of some rules like HIPAA, have had to do more with less information. Those regulations are coming across other industries. There are whole startups now that are dedicated to going out, finding patients, collecting all of their data, and actually monetizing that data for them, right? That's a little bit, that's not great for people like me in that space, because it becomes then very expensive to do something that's already relatively expensive to do. But I think giving people back control over their data is important. I think them volunteering anonymized data that's wonderful, right? Because that gives us a whole host of applications, right? We don't take one person. If we had a lifetime data set of even 100,000 people, the value that has over the data set that I have today for millions of people is vastly different, right? So that kind of an application would be wonderful. Finding and generating the buy-in for that and staying away from monetizing that may pose challenging, but that would be great.
Do we think that we'll ever be at a point where it's almost a requirement to provide the data? And I'll again go back to an analogy, right? A lot of people didn't get an easy pass because they didn't want to share their data, right? But they changed the game. They got rid of the easy pass, and now they just track your license plate and they don't ask your permission. So does that need to happen in the healthcare industry for the benefit of the greater good? We're going to take the data, we're going to, keep it anonymous as much as we can, but is that for the greater good? And I'm not saying it is, I'm just posing the question, right?
Well, that's where public health certainly comes in. And when I was speaking about immunizations and practices being able to give accurate dosage information across the state, it's so that the state themselves can use that information, create insights, and then really deal with the public good. I certainly agree that to a point, we all come to agreement what the public good is. When it comes to, I think, Judith's questions, particularly around clinical trials, you have to put yourself in the position of a patient who's been frustrated with the diagnosis for many years and would love to be included in a clinical trial themselves. But being a part of a clinical trial, you have to go through, the provider have to invite you, the providers themselves have to be part of an IRB. So I think that once, again, on the app side, this is another opportunity, right? Can somebody develop an app where patients can say, I want to be a part of these clinical trials? I mean, I think that will, again, you have an engaged audience. Let's build something that moves them together, right, and puts them all together. And I think that's where we're at. Where is the engagement? Where do these technologies apply the most, and where you get the engagement? Because the data is just so powerful, really, behind that. So
I think the other thing we have to acknowledge is there's a certain amount of data that's already being collected all the time. And, I'm much more aware of it because I'm consuming it and understanding where it's coming from and recognizing that lots of people who this data belongs to don't realize what it's being used for. So I think some of the voluntariness of, hey, I'm going to give you my data gives back more control to the patients in the sense that at the very least they understand what's being done with it. Right? But I mean, especially consumer-based data that we go out and we purchase, I don't know that people who are shopping on Amazon realize that their purchases of soap and the frequency at which they purchase soap is being worked into our model, which predicts your likelihood to get a hospital-acquired infection, right? Like many people, they probably wouldn't make that assumption, right? They probably assume, yeah, Amazon's going to use it to say I should buy more soap 2 months from now. But did Holy Name was using it to predict whether the next time I show up at Holy Name I get a hospital-acquired infection?
No, and Amazon will calculate your usage rate and include it in your next package that you get from them at the approximate time. No, that's true.
Right. And then Amazon's calculation about how likely you are to repurchase that product is also then passed to us, which is also factored into whether or not you get a hospital-acquired infection or not. If you're more likely to purchase soap on a regular basis, as an example, right? This is a very broad example, but that is being factored into those types of models, right? So do people understand everywhere data is being collected and everywhere it's being consumed? I don't think we've reached that point yet, but I think if we create a system that allows more voluntariness, then it opens the door for people really understanding, where all this data is moving and who's using it and for what.
Carl's analogy to EasyPass is interesting because if memory serves, some of you may remember when it was first implemented, one of the things that was a concern was, were they going to be able to use it to track your rate of speed when you got on a turnpike at exit 1 and got off at exit 9 and said there's no way that you could have gotten there unless you were exceeding the speed limit. And they don't do that. But it was an interesting, I remember the concern that was expressed at the time. Okay, next question. Sir, wait for the microphone, please.
Thanks so much. So my question is about adoption.
And your name?
I'm Alex Chu. I'm an emergency doctor. I work for Air Visits, and we do a lot of the technology. The main thing for my group in multiple states, and I'm one of the other directors, is adoption. And when we go into hospital systems and we practice medicine, very high tech. So Carl, I got your dashboard with food tracking within your fridge and actually at the grocery store to make decisions. Then I've got your real-time glucose monitoring and motivation to be able to get your insulin and be able to take it and be compliant. And we have the back-end AI to make sure that all my docs practice the guidelines properly because the computer is better than 10 years of going to CME. Now when we go into a hospital, though.
Soap.
Oh yes, and to use the soap to reduce those problems with infection. But the problem that we have is, I go into a hospital. It's great. We can do all this amazing stuff. We get the full census of the patients. We're able to practice and reach much better outcomes. But then it's just us. And when I try and get the cardiologist to be able to do this, and we have cardiologists too that are virtual, they will come on for a little bit, and we incentivize them. They can make money on this. They make more money on this than they do for normal practices. But then the adoption drops. Same thing with the endocrinologist. Same thing with the primary care doctors. And now the patients are coming to us and saying, well, it's so much easier to do things with you. You keep us on track. You're motivating us. We're more compliant with you. We like talking to you. Great, but can't do everything virtually. Got to do something that's in person. So coming in to health systems, even small practices, and saying, okay, we're going to be the trailblazers. I'm going to show you how to do it, but the adoption just drops after 2-3 months with the on-site providers. So now everything is virtual, and you can't have everything virtual. Right. Got to have that tactile exam. Got to have something in person, that relationship on the ground too. So I want to pose it to the panel, but also there's a lot of other people here that are doing a lot of technology. How are you attacking this adoption problem with the culture change? Because we can be the trailblazers, but then the rest of the entire state, I mean, we're born and bred in New Jersey. We're New Jersey docs doing this. How are you guys doing it? What barriers are you facing? And what are you using to be able to get the on-the-ground facilities, providers, even the ancillary staff, just to start to move in this direction? Because they'll do it, but it's like the hardest wall that we're coming up with. Yeah. Are you guys getting it, and what are you guys doing?
Yeah. I think this is where your game theory example came into play, right? Like it's about leveraging, math that other people were doing for a long time, right? So, as crazy as it sounds, why do people play video games for hours at a time, right? Why did Starbucks purchases go up as soon as they launched stars on their application? There's a mathematical theory behind how people interact with these types of systems, and when you make it more like a game, right, people will interact more like a game. So incentives are great, but it's the money only brings you so far, right? There's a novelty to when you bring something new in and people get excited, but then when the newness wears off, people become bored. So how do you continue to engage them? I think it's where EMRs have fallen short because their focus was on the billing. It wasn't about engaging the provider to continue to use the system. The assumption was, well, of course, they'll always just use it, right? So any application has to be framed within the context of not just, hey, is this cool today, but how do we keep engaging people to continue to use it? And I think our applications of technology have to be designed in a way that we're aware and we're actually making efforts to continuously engage people. Yeah. Otherwise, to your point, it will wear off and people will stop using it, and then it is of no value. Yeah.
But does it wear off for everybody, right? Because sometimes people just don't want to be helped, right? Or they don't want to help themselves, right? It's like dieting, right? I want to be healthy, but I really like good food, and it all sounds appealing when I'm dieting, but the reward pays off and it gets boring and it's old. So to the point, can we help everybody? Are your statistics so dramatically, radical that it's such a drop that it's really not working? Or are you just not happy with the results? Maybe the proof is you're getting a 10% return on this investment, and that's actually a good return. Yeah, and it doesn't always have to be great.
It was less actually on the patients, but more on the facilities and the providers. Yeah. So the Congressional Caucus actually has this problem too. They passed a whole bunch of laws on telemedicine. They're giving real cash to facilities across the country. But then the caucus came out to different organizations, the ATA, and also other types of organizations that have lobbied for the parity laws that we have here in New Jersey. Yeah. And they're saying that the adoption is not where they thought it was going to be for providers and for facilities, not for patients. I mean, for patients, we can motivate them. That's fine. Now, as we go in, we want to change the culture, change their providers. What is your experience in terms of when you try and go and implement your AI or other types of technology? What is your experience? Because we're getting less than 10% that are going to sustain the change. Now, we get about 50% that start, sexy, it's great, we get more money, it's better than anything else for all the patients, and then the whole culture brings in and then drops out. Yeah. And that's what Congress is saying too. And then when we're advising them, we're showing them our data and saying, hey, we're experiencing the same exact thing you are, no matter how, as a country, can we change some of these other terms?
Yeah. And I don't think will you stop though? You won't stop continuously improving your processes based on this. Right. And so I think what I want to highlight based on what you said, and then I'll answer your question specifically around my experience, is we're constantly talking about a feedback loop. This feedback loop of information. Did it work? Did it not work? Why did it not work? Hence why we need the data so that we can have informed decisions. Practically speaking, we're talking about change management at an office, complete change management. And that is, some of it is business 101. Some of it is also, let's look at what works out there. So what we've seen work is physician leadership. We've seen a strong champion. We call them physician champions in the office that are basically getting everyone together and saying, this is where we're moving. We're not happy that we're below the benchmark compared to our colleagues. Second is, let's attend these conferences. Let's talk to these colleagues that are out there because I want to know how they did it. Well, they have a staff of 3, so do I. I have 4 mid-levels, so do I. So, and again, that's all part of this feedback loop as well. We had, so NJBIZ received a grant from CMS around practice transformation and around studying best practices that drove results and then going into other practices that are similar and basically implementing change management. Let's transform the practice to the same 24/7 across the weekend, just like this practice, because it helped reduce admissions over the weekend, right, for the hospital area. So, and we got negative feedback. We got practices that didn't do that because their patient population and the staff that they hired were not, they didn't fit that mold yet, right? So, and it was a 4-year experiment, right? And I think what we're talking about is continuous quality improvement, continuous feedback loops. But I can't emphasize enough. I think being able to express the best practice and saying these are the steps I really took to fix this and to achieve the results that I had. And then you have a physician champion and some leadership in there as well. I've certainly seen that those 2 areas, I think, helped and actually saw results from that.
Any final comments on this one? Because we're going to have to wrap it up shortly.
I think the other thing that we found successful is sometimes shutting down alternative technologies, right? So at times, those workarounds that exist, and the reason people go back to them is because they're still there and they're still usable, right? So sometimes it's a person and you need to find a new position for them. Sometimes it's, the actual system itself or functionality within the system. So as much as you can shut down those alternatives if you're trying to coax people to use a new technology, if there is no alternative, they'll kind of be forced to stick with it. But that goes back to the change management piece of, guys, don't go back to the alternative, right? Focus on moving forward.
Right. Excel. I love my spreadsheets.
Yeah.
I love them. They have colors and everything.
Let it go, man. Let it go.
I can't.
Okay, the hour is nearing, so we'd like to invite you to provide your concluding thoughts, and with all due respect to Jim Kramer, let's do it lightning round style. And I'm going to pose a question and ask you to each respond to it. The question is, we've talked about all these extraordinary developments. What still, in your view, respective view, what still needs to be done? And if you had a magic wand, what's the one thing you'd like to see happen in the next year within that sub-question? Who's going to start? Emma, let's start with you.
Sure. So universal healthcare blockchain, right? So it's a buzzword, but it would basically mean that everybody's health information is all stored in one place, and the patient is the ultimate kind of decision maker in terms of who sees what and when. Massive undertaking, but could be huge for quality, value and technology.
Nice.
Carl?
I put too much thought into this. For me,
Don't take mine.
yeah, I think education, making it so it's not so scary, right? I think people leave a discussion more scared than when they walked in when it comes to healthcare sometimes, and educating more towards the positive of how it can help sort of the greater good, right? How can we do that? Because there's always the contradictory and the scary, but how can we educate towards the greater good to make some real innovations here to really make a change in care?
Great.
That was
Dan?
actually really what I was thinking as well. But let's add some technology. What about I would like to see an application that does promote education, and in particular, in the young New Jerseyans that are growing up here at elementary school. Starting from there, I never learned about health technology and a portal app and things, but there's an opportunity to do that. I think especially in schools nowadays, and going into sports. I was in sports my entire life, and so my concussion history is not anywhere. My immunizations aren't anywhere. I would love to educate the population now today, the younger generation, about the value of this greater good and health IT and how it could be valuable. And I think that will help us a long way in terms of the future population that will be doctors and also patients at the same time.
Well, Lieutenant, I think we've only scratched the surface this morning, but I think this has been an extraordinarily robust and informative panel. So please join me in thanking them for being with us this morning. Now I'm going to turn it over to Jeff for some closing remarks.
Thank you, Dean Paranicas, and thank you, Van Lee, Carl Scalzo, Emma Yamada. As always, we'll have full coverage of this discussion later today on NJBIZ.com and in our next print edition, which comes out on September 9th. We'll also post a video of the proceedings on our YouTube channel in about a week or 10 days. Thank you to Kane AV for handling the video work. If you want more information about Kane and all the cool things they can do, just stop by the registration desk. I hope you can join us if you can for our next discussion, which is on manufacturing on September 24th. That's here at the Doubletree. I hope to see you there. Thanks for coming, everyone.